And in the posterior compartment prolapse, you have to talk about rectocele and enterocele. In the apical compartment, you have to talk about valve prolapse and uterine prolapse. In the uterine prolapse, you have to write about first degree prolapse, second degree prolapse, and third degree prolapse. This is the further subclassification of uterine prolapse. Okay, so uterine prolapse is classified differently and is graded in 3 degrees depending upon severity of the descent. Sorry, the first degree prolapse is uterus has descended from its normal position, descended from its normal position, but still lies in the vagina and nothing appears outside vagina. Okay, the patient comes to you and tells you about discomfort, but on examination you do not find anything, so it still lies in the vagina. It still lies in the vagina and nothing appears outside the uterus. So then what is secondary degree prolapse? The uterus has actually descended to the level where cervix appears outside introitus. It has actually descended, and the body of uterus lies within the vagina. So the vagina has disappeared, you can say, and the body, because the body of the uterus is lying in the vagina. This is the second degree. And the third degree prolapse is this is the extreme form, and whole of the uterus is lies outside introitus and is commonly associated with cystocele, enterocele, and rectocele, because it is putting pressure on the bladder, the urethra, and the rectum as well. So the patient comes with multiple complaints, and this is also called procedentia, which is a complication of untreated pelvic organ prolapse. So what are the risk factors? Risk factors are when there is trauma to the pelvic floor at childbirth, in multiparous women especially, then genital tract atrophy, which is associated with menopause in post-menopausal women. And then we go to raised intra-abdominal pressure in a patient who had a chronic, prolonged, or untreated coughing, or chronic constipation, or heavy lifting, a job that is related to heavy lifting, that they are in at a risk factor. And pelvic masses, then congenital weakness of the pelvic support. Congenital weakness is also seen. How is the scenario asked? Keeping in mind the risk factors and what we have discussed, a 26-year-old para 1 has presented to you with symptoms of pressure perineum and mass introitus. So there is something mass in the introitus. On examination, you see that cervix could be seen at the introitus. Cervix is normally not visible down below, but when you can see it, but not greater than 1 centimeter below the introitus. So she is at a second degree prolapse. Okay, it is the uterus, when the uterus lies outside introitus, that is third degree. But when it is but when the cervix appears outside the introitus, then it is second degree. So you are define prolapse. What is the degree of prolapse? It is a second degree prolapse because the cervix appears outside introitus, not the uterus. When you are asked uterus lies outside introitus, that is third degree prolapse. But when the question is that cervix appears outside introitus, that is second degree. And what is the management? We are going to study that as well. Moving on to the etiology. To understand any disease, any complication, any complaint, it is very important to study its etiology. First of all, multiparous women. Multiparous women, the chief factors is one of the chief factor, and the damage and weakening of pelvic floor is directly related. I have drawn this so that you can always remember this point, that the damage and weakening of pelvic floor is directly related to number of childbirths. More the number of childbirth, more the woman is at risk of weakening of the pelvic floor and multiple injuries to the pelvic floor, and and multiple injuries to the pelvic floor and lacerations or forceful delivery. So more likely, multiparous women are more likely to be at a risk of getting pelvic organ prolapse. So the number of childbirths and is directly related to number of childbirth and is more likely to occur in the presence of prolonged and difficult labor, when the labor is very prolonged or it was a difficult labor, when bearing down before full dilation of cervix, which puts pressure on the vagina and the pelvic wall. Okay, then laceration of lower genital tract in second stage, forceful delivery of placenta in third stage, and inadequate repair of pelvic floor injuries. All of these in a multi, plus the woman is multiparous and are at a greater risk of developing pelvic organ prolapse than menopause. Why menopause? In women, the tissue tone is maintained by estrogen during reproductive age, which is decreased at menopause. When estrogen is decreased at menopause, the estrogen withdrawal results in weakness of pelvic floor. So the woman postmenopausal, the incidence of pelvic organ prolapse increases. Then raised intra-abdominal pressure. Rise in intra-abdominal pressure is transmitted to the pelvis, and there is stretch upon the pelvic floor, making the pelvic floor weaker and leading to more chances of uterovaginal prolapse. What are the different reasons in which there is raised intra-abdominal pressure? Particularly, and these reasons are particularly important to take note of in multiparous women, okay, because already their pelvic floor is weak due to different causes, and then they have these symptoms as well. Cough, not just any cough, chronic cough, which is associated with asthma, chronic bronchitis, a TB, a chronic constipation, and occupations involving heavy weightlifting. Then uterovaginal prolapse may also be caused by constant pressure on pelvic floor exerted by abdominopelvic masses and ascites. Then there are iatrogenic factors, and prolapse may follow pelvic surgery such as vaginal hysterectomy. Then a scenario, this is a very simple scenario, um, but you can only diagnose it if you know about the etiology. A 60 years old postmenopausal lady present with pressure perineum and something coming out at introitus. So she is menopausal and something coming out at introitus, pressure perineum. It is a confirmed diagnosis of pelvic organ prolapse. But you're asked about the DDN management. A 30 years old para 4, so she's multiparous, history of sensation, something coming out of vagina. This is a very specific question, giving a specific statement given in Arshad Chauhan, that the patient complains something coming out of vagina, and it is asked in the same wordings in the past exam questions, that something coming out of vagina with dragging pain. I will tell you about the cause of dragging pain. What is the diagnosis, additional features to ask about, and what is the treatment. So moving on to the chief complaints. Okay, as I told you earlier, that the chief complaint or the presenting complaint is common. The chief complaint that is common in every woman is that something coming out of vagina. Okay, this is the chief complaint which every patient presents with, not considering her age or her parity or anything else, but she says that something coming out of vagina, and it is aggravated on coughing and straining, and long standing, straining at stool and long standing. And the prolapse reduces spontaneous only on lying down, though in extreme forms it may stay out. And then the associated symptoms, the other presenting symptoms depends upon the site. Okay, this is very uh, this is very simple to understand that other symptoms will always depend on the site, the type, and the complications of the prolapse. So if the patient has uterine prolapse, she will complain of dragging pain in the lower back, lower low back. By the word dragging pain, as you have seen in the previous scenario, that the same wordings are used for pain in pelvic organ prolapse, dragging pain. The discomfort is caused by abnormal tension on nerves in the tissue that are being stretched. So the patient complains of dragging pain. Then there is bleeding. Postmenopausal bleeding may be a presenting complaint if prolapse is ulcerated, and bleeding with purulent discharge in case of ulcer getting infected. Coital difficulty or dyspareunia is a complaint in uterine prolapse. Then vaginal prolapse, which in vaginal prolapse, think about it as if the patient has cystocele or cystourethral seal. It is the prolapse of the bladder, so the pressure is on the bladder, and the patient will predominantly present with complaints related to urinary tract. That is stress incontinence, frequency and urgency. In severe cases, the patient may complain of manual reduction of prolapse prior to maturation. Okay, and then if rectocele, if the patient comes with rectocele is often asymptomatic, but it may sometime present with something coming out of vagina. The patient may complain of backache, pelvic pain, and coital difficulty again. And a large rectocele may uh, uh, in a large rectocele may sometimes cause difficulty at defecation, and the patient may have to reduce prolapse digitally for completing uh, emptying of the bowel emptying of the bowel. Then moving on to intracele and vault prolapse, the patient often complains of perineal heaviness and pelvic pressure only. And the diagnosis, the DDs, these have been asked as well in your exams, that what are the DDs. So Gartner's cyst, urethral diverticulum, periurethral cyst, vaginitis, valvular tumors, and cervical hyperplasia are the differential diagnosis.